Okay, so this is chapter 28, the assessments of suspected substance use disorders. The theory behind substance use assessments. The use of a substance, even if it's legal, does not prove presence of an SUD. Inexperienced healthcare workers may make this error. Assessment is not a one-time procedure, rather it is a first step in a process that should continue during treatment. Screening identifies those who might have a given problem. Assessment follows, which may or may not lead to a diagnosis. Screening 104. The core of the screening process is the clinical interview, which allows for an overview of the client's substance use patterns. Information is gleaned from a variety of sources, including collateral information, questionnaires, past records, and biological testing information. Verbal screening aids. There's the CAGE system, the MAST system, the TWEAK, and single question assessment. Paper and pencil / computerized screening instruments. Inexpensive and less threatening to client. Vulnerable to deception and assume client is literate. Alcohol use disorders identification test. Substance abuse subtle screening inventory, and then there's a drug abuse screening test. Beck depression inventory. Minnesota multiphasic personality inventory with the McAndrew alcoholism scale. Assessments 105. Following screening, attempts to measure the severity of the individual SUD. Must be aware of the pull toward diagnostic inflation. 3 formats: unstructured, semi-structured, and structured. Often done with the framework of the DSM. Useful for assessor to ask different questions during the interview that are designed to explore the same client response from different perspectives. Clinical interview may offer benefits over the semi-structured or structured interviews. Flexibility, better establishment of rapport, reassuring to clients who are uncomfortable working with a computer or written assessment tool, allows attention to nonverbal behaviors. Attention to 4 different response sets: disacknowledged, misappraisal, denial, exaggeration. Psychological test data may directly or indirectly assist assessment process. Standardized tests: alcohol use inventory, addiction severity index, the structured clinical interview for DSM, drug use screening inventory revised. The assessment format 1 of 3. Stepped diagnosis includes 6 steps. Gather baseline data, normalize problem, watchful waiting, minimal intervention, brief counseling, forming final diagnostic, and initiation of treatments. Circumstances of referral. Why is the client here today? Substance use patterns. What has the past looked like? Past treatment history, first attempt or repeated treatment. Legal history, nature of past legal charges and outcomes, nature of any current charges, past militant record, important yet often overlooked source of information. Educational / vocational history, development and family history, psychiatric history, again often overlooked but very important as part of the comprehensive assessment. Medical history may provide information regarding initial source of SUD behaviors. Real versus pseudo personality disorders, the assessor and data privacy. Diagnostic rules 1 of 2. Many individuals will resist a diagnosis of SUD, at least at first, and so 2 rules must be followed. Always gather collateral information. Those with an SUD are responsibly accurate, but if facing legal action, may exaggerate SUD as a mitigating factor to other charges. Yeah. Others may underreport, often out of fear of losing some entitlements. Always assume deception until proven otherwise. Clients may consciously or unconsciously distort information, possibly due to distorted way of thinking. Even cooperative clients might engage in deception, perhaps without realizing that they are doing so. So other sources of information, medical test data. No definitive blood or urine test to prove addiction. They can simply indicate when usage has occurred. While a single dirty test does not prove SUD, a series of 3 or 4 tests may be more definitive. Medical tests can often confirm the presence of certain chemicals in client's body, identify the specific components present. Possibly determine the level of chemical in the body, hint at how long the patient has been abusing chemicals. Diagnosis, the outcome of assessment process. 4 interrelated questions should be answered. Does the individual have an SUD? How severe is the substance use problem? What is the client's motivation to change? What are the factors that contribute or support further substance use? Treatment referrals. After assessment, next step is to determine appropriate levels of care. ASAM criteria and levels. ASM levels of care. So there's level 0.5 early intervention, level 1 outpatient treatment, level 2 intensive outpatient and partial hospitalization, level 3 residential inpatient treatment, level 4 medically managed intensive inpatient treatment. Treatments are guided by the principle of the least restrictive treatment alternative.